Welcome everybody to another EHE COVID-19 webinar event in our series that's now been going on for close to a year. Right now we're in the period of the COVID-19 vaccine rollout, and that's what we're going to talk to and speak about today. And in particular, how do employers fit in with respect to this rollout? My gosh, in the past few weeks, we've had a whole bunch of new and changing information, to say the very least, not only 2, now potentially 3 or even 4 new vaccines. We've got issues of new variants, big questions about what vaccine and what variant, issues about masking, double masking. We have issues with respect to employers making this mandatory or not. How do we communicate to people? So there's a lot to catch up on. And it's really my pleasure to have 2 fantastic guests today to help walk us through this. Many of you already know Dr. Bernard Camins, who is the professor of medicine and the head of the professor of medicine at the Icahn School, Mount Sinai in New York. And he is the director of infection prevention and really responsible for rolling out the program, not just for Mount Sinai, for the staff, but also for patients. He has a distinguished background and career. He was a member of the CDC Outbreak Response Training Program and Planning Committee. In that role, training epidemiologists and others how to cope with these epidemics and how to plan. We also really are privileged today to have Dr. Lydia Campbell, who I have known now well for a few years. She is the Distinguished Chief Medical Officer at IBM, and she's responsible for the Corporate Health and Safety program. She's in charge of all of the strategic programs relating to the implementation of workplace safety and health, and really has a bird's eye view on what all the incoming issues are, and with her colleagues and her network of friends really helping shape the employer response to what's going on today. And as we all know, this is all uncharted territory, and what we can do the most of is connect with each other and learn from each other. And I think we're going to have the benefit of Dr. Campbell's bird's eye view on all of this today. But let's jump right in with Dr. Camins. Really where we're at is trying to reduce the lethality of this epidemic. We've got all these vaccines. We've had a whole bunch of changing fortunes with respect to infection rates. It seems to have peaked in most of the country. Hospitalizations are starting to downturn a little, maybe fatalities not so much. We expect that to happen. But we've got a lot of things that are changing and will change in the next few weeks. And why don't you take a few minutes and just summarize some of those changes for us? And what we thought we would do is we'll put up a chart here to start with. What vaccines do we actually have right now, and where are we going? And by the way, as a reminder to everybody, we have a Q&A. We generally reserve at least half of the session for Q&A, and that you can just type your question into me in the Q&A, and I'll direct it either to Dr. Camins or Dr. Campbell. So I'm going to share the screen, and Dr. Camins, tell me if it's coming up okay. You're on mute, Dr. Camins, so yeah.
I can see it. So thank you for that introduction, and welcome to everybody. It is my honor and pleasure to address the group. I think it's been great to be part of 2 different webinars before. So I think everybody has heard about Pfizer and Moderna. Those are the first 2 vaccines that are available, and they are mRNA vaccines. So while so it does sound strange, or people tend to say, well, it's genes, right? mRNA, and people are afraid it's going to incorporate into your DNA and cause mutations in your body. It does not. It will not. And that all it does is that it only has the code for the spike protein of the coronavirus, and that is what's going to be produced in your body. And so that's what will be recognized as an antigen or a foreign material, which then primes your immune system then to create antibodies to prevent you from getting infected again. The other that was discussed before, although not available in the US, but available in Europe already, is AstraZeneca. And that has the same mechanism as the new Johnson and Johnson Janssen Pharmaceuticals vaccine that was just released their data, although the full data is not available yet, but it is available on the website, and they are submitting it to the FDA for review to get an emergency use authorization. Both of those are actually adenovirus vectors. So they take in an adenovirus, which is the same, very similar to the virus that causes pink eye, or the one that gives us a common, cold in the past, and they actually modified it so it won't replicate, but then it does make, again, just a spike protein, which then will be released into your body, and your immune system will recognize it as foreign. So it's very similar. That's why people are, some of the side effects that have been reported with the Moderna and Pfizer are very similar to when people have when it's in the spring or fall, when people have problems with mold or pollen, and I do that. So I take Zyrtec, daily because of my allergies. And in the spring, sometime for a few days when the pollen's really active, I get muscle aches, I get fatigue. But having had 2 doses now of the Pfizer vaccine, I actually, aside from soreness in the arm and maybe a little bit, sore, like my upper arm, a much bigger area than my than the vaccine site, I actually was able to work out the next day, only because it felt good to have both doses. So, but I didn't get hit by, although I did had to sleep a lot more that week. So this was just last week when I got my second dose. So again, a third of patients who receive the Pfizer and Moderna vaccines do not have any side effects to speak of, while there are some people who develop fever. Um, and then the last one, which Dr. Levy actually reminded me of, I think the Russian Sputnik vaccine is also available now, and they also have published their phase 3 trial in the Lancet just today, and I just got a quick glance of the abstract. Again, that is also an adenovirus vector. The last one on this list, which is actually I'm looking forward to, is Novavax, and that's actually what we're used to, such as like the flu vaccine. So what it is, it's just they're going to take the viral protein from the coronavirus, and they're going to give you an adjuvant. So we already have that, something called Fluad, right, which is a flu vaccine that has an adjuvant that increases your immune response to the flu vaccine. So Novavax is probably and they're already they have completed the trial, I believe, in Europe, and they're still enrolling in the US. And so we will have that potential 5th vaccine available soon. The AstraZeneca, I think one of the holdup was, it's not that the data wasn't good or that it's not safe, but unfortunately the company, when they reported the data, it just seemed a little bit, there were some issues with data that they reported. And here's the deal. There was a greater than 90% efficacy if you got half a dose, the first dose, and the second dose, a full dose, versus 2 full doses. They had a lower efficacy, but it was somewhere around probably 70 to 80% versus it was 90% for 2 different doses, and somewhere in the high 60s for if you had 2 larger doses at the same time, which is hard to explain, but that's what the trial showed. So that's why it's being reviewed a little bit more carefully in this country. And so it has not received an emergency use authorization yet. So those are my opening comments on the vaccines, and we can talk about it some more. But so I think the other things that we need to talk about is who, so I already talked about who are the next group to be prioritized. Now, that is looking through a crystal ball. I actually had no idea. In New York, I found out that 65-year-olds and older were going to be included the day the DOH released that the attestation form where they just change it from 75 years to 65 years. And again, unfortunately, even though there are guidelines released by the CDC and others, that none of the states are exactly the same when it comes to priority lists. I am hoping that the next list will be probably at cutting it off at 55 and those having a pre-existing condition that would put them at high risk. That's a huge number, right? And that again, just getting through 65-year-olds or older may take us 6 weeks to finish vaccinating them, or even longer. That adding that group, the next group, will be very difficult, and and the definition, there'll be plenty different definitions for it. So again, we'll just have to wait and see what the ACIP, or the advisory committee on immunization practices will release next, and see how we would prioritize them. I think there is a push for the federal government to standardize at least priority lists for all the states to make it easier, especially if we're going to have chain pharmacies like Walgreens and CVS give out vaccines. It has to be uniform. Um, I'll talk about the variants a little bit now. The caveat here is that we don't know if we actually have homegrown variants already, right? So at least as a country, unfortunately, we have not done very well in controlling this outbreak. And how mutations occur is when virus replicates. So because we have uncontrolled infection in this country, spread of the coronavirus, that I wouldn't be surprised if we have our own homegrown variant that's very potentially could be not as sensitive to the vaccine, or have mutations in the spike protein, which makes the vaccine less effective. We certainly know that about the South African variant. The UK definitely variant, although is more infectious, seems to still be okay in terms of the vaccine now. But the good news about our current manufacturing process is that the Pfizer, Moderna, AstraZeneca, and even the Johnson and Johnson vaccines can be altered slightly to then meet the variants in a couple, not a couple of weeks maybe, but a couple of months, where they can start producing vaccines with new genetic code that fits a little bit more of the circulating virus. Very similar to what happens with the flu, right? That's why we have a yearly flu vaccine, because the flu and it's the flu virus is more prone to even mutations than the coronavirus. So again, uh, I hate to say this, but I've said this before. Just vaccinating the population will not change the way we do things. We will do this slowly, um, and it will mean, even if we have herd immunity, we will still continue to have infections, right? And potentially even deaths. But one thing I can tell you, with all the numbers, people are saying, well, should I get the Johnson and Johnson when it showed it was less effective? The one thing that I can say is that so far, all the vaccines, the people who have received the vaccines compared to placebo, none of them have died from COVID-19, right? So again, the vaccines, you can look at definitions. Is it severe? Is it moderate disease? But what we know is that it actually has prevented people from dying from COVID-19, right? So until we have more people vaccinated, until the cases go down significantly, we still need to continue the non-pharmacological interventions, such as social distancing, wearing a mask, and avoiding indoor gatherings, right? Because I think the variants are here already. We have our potential homegrown variants as well that we just don't know about yet. And so we need to continue our efforts in that. Last two things, double masking, because that has come up. Again, if you're wearing a cloth mask, certainly wearing 2 layers of the mask will protect the wearer more. But to protect everybody else from the person wearing the mask being an asymptomatic carrier, even one mask, as long as it's not a made out of flimsy cloth like a bandana or a gaiter potentially, um, even one mask for everybody to wear is actually adequate to prevent spreading of the virus. But to protect yourself, having multiple layers is probably much more protective. And the last one is, it's probably, you don't really have a choice. People have talked, can I mix vaccines? If I did the first dose with Pfizer, can I do the second dose with Moderna? Actually, you really don't have a choice right now. Right now, since the government is giving us our vaccine, all the vaccine pods will look, if you got Pfizer your first dose, you'll get Pfizer as your second dose. If you got Moderna as your first dose, you'll get Moderna as a second dose. And somehow if the Johnson & Johnson vaccine comes into the mix, you will get one dose of the Johnson & Johnson vaccine. And how it gets allocated, we don't know yet. But I can tell you what we have been telling people who come to our vaccine pods is, get the vaccine that's available when you show up, right? Sometimes you just don't have a choice because supply is limited. That's all I have for now.
Okay, that's great, Dr. Camins. So I just want to summarize just a high level point that you made. And I think it's really important that, you listen on television and, this vaccine has a 70% effectiveness. This has 95%. This one has 80% after one dose. But I think what you said is really important, is that vaccine effectiveness, namely the ability to prevent from actually getting disease versus the total prevention of lethality. All of these vaccines out there, you can be almost 100% certain that when you have been vaccinated, you are very unlikely to get, if you do get COVID, very unlikely that it's serious and almost impossible that you die of COVID. I mean,
Right.
that's what the data is showing. So if a vaccine becomes available that is not the Pfizer or the Moderna, the correct answer is yes, please, and thank you very much, right?
Right.
You run for it and you run for it quickly. I mean, is that a fair statement?
It is. I mean, the same message with flu, right? We've never had a flu vaccine that was 100% effective. On the best, it was 60% effective. But what our message is that, but if you get the flu, you're less likely to get really sick from the flu or die from the flu if you get the flu vaccine, because it's only partially effective. But for young people with good immune system, the flu vaccine really works. And so for the same reason, these vaccines certainly, probably works better in kids or in young people who have really good immune systems. But again, yeah, that's the take home message.
Okay, great. So let's move now on to Dr. Campbell. Just to get us going here, look, we live in a really polarized, mistrustful environment these days. And it turns out that employers really have assumed a level of trust and leadership, frankly, that has been kind of disappearing on other levels of our society, from government or from other institutions. And I think we'd all agree that employers do have a special responsibility with respect to preventing fact-based evidence and a good communication and guidance. And I know that you and IBM take that role very seriously. So there's all sorts of questions about those who are more vulnerable. How do you protect your workforce? What do you kind of mandate versus not mandate? How are you handling all of this? And perhaps you can give us an overview and in fact also tell us about what some of your colleagues are also thinking too, in terms of your own network of chief medical officers around the country.
Thanks, David, and thanks to everyone for the invitation. This is truly a topic that's been front of mind for myself, for my team, and for many of my colleagues in the industry for greater part of a year. And I think where we started at IBM with this is with the acknowledgement and kind of to level set our corporation that this is first and foremost, right, a public health emergency, right? We're part of the ecosystem that is being impacted by that. I would argue a very important point, as you've alluded to, because so many people at the beginning of this, when things were just ramping up, hospitals were overcrowded, doctors' offices were unavailable, either, again, attending to the most critically ill patients, it was difficult to get to, credible information. And I want to thank Bernard for sharing information. Information truly is power. But one of the things I think and responsibilities we have as employers is to give our employees, the people that we are responsible for, access to timely, transparent, accurate, and trustworthy information. And so I think to that point, David, one of the tenets of our response plan as it pertains not only to vaccines, which I know we're talking about today, but from the very beginning has been really to be, from a foundational standpoint, based on, or to make our decisions based on the best available science and evidence as a primary takeoff point. From there, to make sure that we are compliant with whatever the public health leaders or governments in the countries where we operate mandate or require. And where that's been absent, that's where the help of my medical director friends and other corporate medical leaders and directors has come in. A lot of things in the times when there was a lot of uncertainty were decided by consensus, right? Or by benchmarking or, kind of bouncing ideas off of one another. And that's oftentimes one of the most powerful tools we have. I think to your direct question, one of the things I think we did well, and I think a lot of my colleagues and other corporations on the call will say, one of the most important things that companies can do, to your point, is represent a trusted source of good, credible information for our employees. Our employees spend, 3/4 of their lives at work, attached to their employer. And so in times of crisis like this, it's important that we not necessarily, again, solve the problem. This is a problem that's bigger than any one company, but be a source of trusted information and of support to our employees. And I think that that's the way that we've approached this, and it's been very, very effective. I think one of the things also that we did very early and that we continue to do is, while there continues to be a lot of discussion and uncertainty about the applicability of testing, when to do testing, which type of testing to do, and on what interval, vaccines are having a lot of the same, or bringing a lot of the same discussions. What we know is that, as I've said on some of my videos, what your grandma and your mama told you still work, right? Keep sick people apart, so social distance, wear your mask, cover your coughs, and sanitize your hands well and often, as well as commonly touched surfaces. So I think one of the other important things that employers can do is, in the midst of all of the swirl around which vaccine is best, which one should I take, when will I get it, is to remind our employees of the importance of, even if you are one of the essential employees or healthcare workers identified for early vaccination, we still need to practice the non-pharmaceutical interventions, for the foreseeable future, right? So I think that's critically important. On the topic that I think a lot of employers are contending with now is, what is our role in the chain of vaccine disbursement and delivery? How do we get our critical employees in particular, but all of our employees vaccinated? I think where we have found ourselves, or where we want to be, is we want to stay informed. So I have a global team. I know we're talking today more to our US-based team, but around the globe, we're monitoring. And to my knowledge, there are only at this point in time 4 countries where there's a prescribed role, or they're considering a prescribed role for employers in actually delivering vaccine. And that's the Philippines, Mexico, Indonesia, and India. Other than that, I think most all of us are waiting. We've just had a change here in the US administration, so we're hoping that some of the information will be a little bit more streamlined, and, as Dr. Bernard talked about, a little bit more consistent in how we approach across all of the different states. But if you can think the states are complicated, move globally and start to look at the different countries and different entities within those countries, and it gets even more complex. So I think the commitment we have for our employees, again, is to deliver credible information about the vaccines. I agree wholeheartedly with Dr. Bernard that a vaccine, any vaccine, regardless of the purported sensitivity and specificity, is better than no vaccine. And to make sure that we're not, quote, jumping the line, not taking valuable vaccine away from our frontliners, those who are, in patient care situations, or, our elderly or vulnerable within populations. But we also, do want to make sure that we're not, quote, proverbially at the back of the line or last in line. We want to stay aware and updated and become a part of the solution for distribution and get our employees worked into and access to vaccines at such time as it's appropriate. The other issue I think that rises for employers as it pertains to vaccine is, again, about vaccine hesitancy and how do we ensure our employees that vaccines are safe. And I think it again comes down to, we are a trusted source. We owe it to our employees, for those of us who are medical leaders in our companies, safety leaders in our companies, to be educated and informed ourselves, and to then share that through several mechanisms with the right level of cultural sensitivity also for those who are part of multinationals, and to help them understand that although this was done rapidly, that no steps were skipped or missed, and that the right level of stewardship was given to guide the evolution of vaccines that have now been approved and are in circulation or available. I also think that at such time as vaccines do become more broadly available in companies, et cetera, that, like with many other things in companies, we should use the power of our executive leadership, of our C-suite leadership, et cetera, to model the behavior of vaccine, of having vaccines, and of expressing their importance in the overall fight against the pandemic. So I can stop there, and I'm sure people have lots of questions, and I'm sure other folks on the phone also may have some opinions around a lot of what I've discussed.
Thank you so much. Could you make a mention of, we talked about this a little bit before, the idea of employer mandate for vaccines.
Yes.
And then Dr. Camins had some observations that we discussed, that there's so many companies developing these applications where show proof of vaccination, which are will be required for entry into certain venues. And this is a really complicated and evolving situation. And it's kind of a backdoor maybe to a mandate. I think your thoughts on this are really interesting, Dr.
Yeah, so again, I think one of the unique things or important things about medical directors who are sitting in companies, and oftentimes I've had this discussion with my peers, is, no two corporations are exactly the same, right? So a lot of what we recommend ultimately to our senior leadership and the actions we carry out have a lot to do with the context and the operational model, right, of the business. So for example, at IBM, we were able very early in pandemic and made the decision to move to a work from home arrangement. And 95% of our employee population are able to do that. Well, for other industries where, retail, manufacturing, food services, et cetera, that's not an option. So whereas we haven't adopted things like wide-based interval testing at many of our sites, the few of our sites, I should say, that are open, because it didn't make sense and didn't seem to add any protection to the mitigating measures we already had in place. There'll be a different story in a manufacturing setting where employees can't social distance, et cetera. So in like form, I think as we've discussed and talked about vaccines and making them mandatory, at this point, our CEO has been very open and public about the fact that we will not mandate vaccines for our employees. I think, everything I have said, everything that he has said has been predicated or has been caveated with the fact that this is based on what we know today. And what all of us know is that the information around and about COVID-19, the new variants that are now circulating, changes day to day. But we right now, just based on the principles we have around how we deliver and occupational health and safety in our corporation, and the business model that we have, don't feel that there will be a need for us to mandate vaccination for our employees. That said, we will advocate. We believe strongly in the power of vaccination. We have long history of vaccine preventable diseases and the effectiveness of vaccines in those settings. So we will encourage, support, and provide access to our employees for vaccination, but at this point, they will not be mandatory.
Dr. Camins, maybe you could talk a little bit about.
Yeah. So the app that I'm aware of, right, is the Clear, which is one of the apps that we use to get through airport security faster, is also working on an immunity, quote unquote, passport. And what I don't know is what the requirements are. Does that mean you have documentation that you were infected in the last few weeks, or is it because you've been vaccinated? But certainly those are things that are already being discussed. And one thing, while employers may not be able to mandate employees, and again, we're really talking about when these vaccines are fully licensed. Right now, they only have emergency use authorization because we don't have data longer than 6 months. But eventually, maybe going to a concert, flying on a plane, it may require us to have some type of immunity passport. And so if that part of your job is flying, then you will, in a way, be mandated, right? Otherwise, you won't be able to do your job effectively. So, so those are things that where at some point employers may not need to, because living life will sort of mandate people to get vaccinated, so, and to show proof they've been vaccinated. So and again, as the panelists are probably all employers, that I think that's probably what we all prefer, because it's an easier question, and I strongly believe in it only because that's our only way out of this pandemic. It won't happen overnight, but again, it'll slowly get us out of this, so we all can. I don't know if life will be normal for at least 5 or even 10 years. Who knows, right? But certainly we won't go back to what was that?
Don't say that. Please don't say that.
Well, how about this? It will be a while before we get back to 2019 like we did, right? There's going to be a lot of things that we need to continue to do, right? And I guess I'm speaking from a healthcare standpoint. COVID will always be in our lives, because when someone comes in sick with a respiratory illness, we always have to think about COVID, and we have to think about if they've been vaccinated, did they, get infected in the past. All those will have to play into our decision making when providing care, but also a lot of things we still need to learn. So yeah. So so there are a couple of questions that are interesting. Should I go ahead and do that, David?
No, yeah. Before we get to those questions, I want to go back to Dr. Campbell.
Yeah.
The incoming administration has said something about asking OSHA to step up work site protection as it relates to COVID. And it's very hard for me to discern how, with the presence of a vaccine, that there isn't an inherent obligation inside of that stepped up monitoring of the work site. And there is a question here that says, just because if you get a vaccine, that doesn't necessarily mean that you are not contagious, and does not necessarily protect the work site. But as an employer, do you feel that there's going to be more and more regulatory bars that are raised to keep COVID out of the workplace?
I do. I think that, we kind of have to wait and see, right? Again, I think that, a lot of us are waiting to see what OSHA will come up with and mandate. And again, I think one thing OSHA, does have the habit or way of doing is to create requirements and regulations that kind of run across all industries and contexts that I talked about, some of which is, good. I mean, ultimately the intent is good to protect workers, which is their mandate, but it doesn't always fit every context and every situation. So I think, as is the case with rulings that OSHA brings, there'll be a lot of comment and feedback from employers as we unveil kind of what their requirements will be. I think testing being a part of that, I'm not sure that I see that being a big piece of what they'll regulate. I think it'll be more about conditions within the workplace, workplace design, more about the requirements around HVAC systems, mask utilization and other things that they traditionally have regulated. I wanted to say, it's kind of in line with this, but back to the question that you asked Dr. Camins, which is, I don't think there's a going back to kind of the normal as we knew it, right? Especially for employers. I think there's a new normal that we'll have that. Unfortunately, we had to have COVID to come to that. But earlier on, I think as employers, we had, avian influenza, the warning for that. We had H1N1. And, I think people may have gotten complacent, comfortable, whatever the right words are with that. And now finally, we had this huge impact. And I think that it's caused people to really pause and think more carefully about, the next pandemic and how do we prepare or be better prepared for that than we were for this one. And so I think looking at, again, things like workplace design, things like, how we do our housekeeping, sanitizing, what kinds of filters we use in our buildings, how do people enter and exit, and is there a combination of work style, work from home and at premise work that's going to be a part of the permanent new normal for employers. So I think a lot of things will change as a result of this pandemic. We'll have a lot of good learning, but I don't see us definitely for the next 2 to 3 years going back to settling to a new normal, because I think COVID is here to stay at some level. But I don't ever see us going back to kind of pre-pandemic state as you know.
And David, since I'm actually speaking to a group of employers who are in charge of employee health, right? So I think Dr. Campbell brought something really important. Like, it took the pandemic for us to realize that what we do in the workplace. So one example is flu, right? So I can tell you how many times people have told me, even in our healthcare system, where if we rule out COVID, but yet the person's having fevers, that we should let them back in, right? I mean, okay, well, it could have been flu, it could be something infectious like bad diarrhea, right? So I think one of the things that I had to tell them, like, well, step back. If they have something infectious, I don't want them at work, COVID or not, right? So we develop policies to say that if it's not COVID, you still have to stay off work for at least 3 to 5 days, especially until your symptoms have improved, right? So those are discussions that never happen, right? People would go to work sick, and we even used to say, oh, they're so dedicated, they come to work sick, and but then they're infecting other people, so it actually decreased productivity in companies because then they infected 10 people with the flu. So anyway.
It is remarkable
Yeah.
how all of these coronavirus protective strategies have really damped down the influenza season. And I mean, that's a great example. We kind of never took seriously those folks who stayed home or wore masks during influenza. And now we've seen how effective some of these, basic interventions are. And I think that those will stay with us forever. And I appreciate from a clinical point of view that, yes, when somebody comes in with an upper respiratory infection or a cough, I think I don't ever see coronavirus ever disappearing from the from humanity. I mean, I think it's here to stay we're not going to eliminate it like we eliminated smallpox. I mean, it's
Right.
going to happen. So it's always going to be a consideration. But again, I think with vaccines, I think we can look forward to a time when the lethality of the epidemic itself can be brought down to at or below influenza-like epidemics, which we lived with pretty well historically. And let's hope, there's a great expression, let's not have the experience and miss the meaning in terms of what we can all do in the future. And what Dr. Campbell said quite clearly, we can learn a lot, and hopefully we tend to forget easily, but I think that there's a lot of great learnings from an employer point of view as well as health systems. But let me just start with the questions now. We have a couple of questions and you can see them too, but this is a great question. Maybe you can bring us up to speed, Dr. Camins, on how is it that vaccinated people can spread the virus? And what is the emerging research on this? It does appear counterintuitive.
Yeah.
For the lay folk out there, like how does that happen?
So the easiest answer is that when they designed the study, they were looking at symptomatic people with symptoms, so cough, fever, right? That is the endpoint. So when the Pfizer and Moderna study said they were 95% effective, they were 95% effective at preventing people from getting symptoms of COVID. Now, the question is, does that mean they will not get asymptomatic infection? The answer is actually no, they will. So some people will, right? So if 1 out of 20 will break through on an ideal, and again, Moderna and Pfizer are one of the best vaccines that we have so far to be that effective. 1 in 20 will still get symptoms. So obviously they're symptomatic and contagious, but they're still just working on the data to find out what proportion of people still can get infected and have asymptomatic shedding. And that is the important answer. So that's why the warning out there is even vaccinated, you still should social distance, because what will help, right? Even if I'm saying the vaccine is not going to be 100% effective in preventing asymptomatic infection, what would help is actually the number of cases coming down in the community. So those people who do not respond 100% to the vaccine will then not be exposed to SARS-CoV-2, which then will infect them even though asymptomatic, so they won't be able to spread, right? So the key is to get back to less than 1% positivity rate with vaccination. And again, so even if we reach the herd immunity of about 70 to 75% of people either infected or already vaccinated, there's still, even in the community, it may not be spread, but 30% of people are still susceptible. So if you bring someone outside the community who is infected and happen to infect that 30%, then you could still have transmission, right? That's why we're going to continue. But the likelihood of you coming down and getting sick from COVID and dying from COVID will be a lot lower, and that will, if you get the vaccine, again, you decrease that chance by I don't know how much, but a lot. Like it's really highly unlikely that if you get vaccinated, that if you get infected with COVID, that you will die from COVID. Again, if that also means that if you need a yearly booster, you should get the yearly booster, because otherwise your the changes in the variants, right, then will make the last vaccine you got not as effective. So,
okay. So the next question is for Dr. Campbell. The White House just announced that they will directly ship the vaccine to pharmacies. While that will definitely help to speed the distribution, what are thoughts around this change and the impact it may have on American employers and how they interact with their employees around guidance or compliance?
So that's a good question. I don't know if that's a better one for me or Bernard, but I will say, I think that providing more distribution channels is key, but it's only part of the solution, right? The saying, the devil is in the details, it really applies here, because the logistics of the actual, so getting them to the pharmacies, having, hundreds of pharmacies, CVS, Walgreens, is definitely gonna get more vaccine out there. The logistics, however, of getting appointments scheduled, getting vaccines into the arms of those who need it is a different story. And I only have the experience of testing to compare that to. You know, we had testing when it was widely available, and we steered employees to certain pharmacies. And there was still, you know, you could go through the scheduling mechanism, which was there, and still have a 3 to 5 day wait, right? So I think what needs to be worked on more than just getting the vaccine to the pharmacies is still the prioritization of which groups will go first. How will you ensure that people can get an appointment within 48 hours of the time that they were scheduled, et cetera? And that would extrapolate out to employers. Now, frankly, I think that employers should become a part potentially of the distribution of vaccine. Why do I think that? Because again, most people a large majority of people in this country are employed and spend a great deal of time with their employers. The extent to which employers can provide space and capability for delivering vaccines, I think therefore takes care of a huge segment of the population if those can be provided at or by the employers on site. So I'm still waiting to see a part of the plan that says there is a role for employers in helping with distribution. And I think that's really going to be where we see actual employees become, have more access, have better, broader access to vaccines. I don't think right now that just providing more vaccine to pharmacies is going to solve for that, because it hasn't done so with testing.
And to just add to your point, Dr. Campbell, would be for people who are ambivalent, they don't care if they get the vaccine or not, but if you make it easy, they'll take it. That's when it makes it easier, right? They're at work 8 hours a day. Can we take 15 minutes of your day to just go down to employee health and get your vaccine? Sure, it's easier than having to drive to the pharmacy and wait in line, you know, for how long.
Right.
It's easier to get it done. And I think to also help answer this is, I think this vaccine distribution was shaped by the fact that the first vaccine to become available is so finicky that you needed special storage, right? If the reverse was true, that Johnson & Johnson was the first vaccine out, which can be stored at -20 up to 3 years and would last 6 months at a regular refrigerator, so 2 to 8 degrees, which is a regular refrigerator, then it would have been different. I think the distribution would have been a lot more available. So they probably would have started at these pharmacies instead of hospitals. And the only reason why hospitals were chosen is because we just have the better equipment, and that there was a run on -70 freezers, right? And that takes a long time to manufacture. So I think the fact that Johnson & Johnson's available will definitely change it. And if someone were to ask me, sure, supply the pharmacies, but also supply employers who have a clinic, right? Large companies that have a clinic or employee health clinic where they can get their vaccines easily. So
I think another quick point to raise here that's been, and I know front of mind for us, has been, the specific question asked about the impact on American employers. And part of the difficulty has been with getting a clear definition around, beyond healthcare workers and at-risk populations. How do you then define essential employees? Who becomes essential? Is it an IT employee who supports, critical infrastructure, hospitals, banks, et cetera, versus someone who's just working on, programming to create the next new big IT, solution? In medicine, I think we've done pretty good by saying, hey, if you don't see patients like myself, you're not that first priority group, right? But I think the further we go down and move away from the clear cut, your patient facing healthcare worker, or you're, over the age of 65, 55, whatever that cutoff is, it becomes more complex to figure out how to prioritize beyond that. And I think that's specifically a problem for employers as we look at our employee populations and on keeping our businesses running.
Mhm.
I think once we get through what they call the 1A, B, and C, and it goes to the general population, those problems will sort themselves out. I mean,
Mhm.
I think in the end. And by the way, I think what both of you are saying is you foresee an era where, just like today's flu shots, employers will be giving them at employer sites, clinics, special events in the fall. Maybe we'll even have a combined flu coronavirus vaccine and one
Mhm.
shot for both. I mean, it's possible. I mean,
Right.
it's not hard to imagine that kind of scenario playing out, in the coming
Yeah,
years.
but until Pfizer fix that finicky vaccine, they're not going to be the main vaccine available out there because it's so hard to deal with. So, um,
Okay. The next question is more infectious disease based for you, Dr. Camins, I guess. Are we gaining any more clarity on whether COVID recovered individuals maintain antibodies and the
Mm.
likelihood of reinfection? That's a raging topic these days.
yeah, so just the same is that our response to the vaccine, 2 doses of vaccine are very different. Each person's different. Each person's also different the way they produce antibodies to coronavirus or to the COVID-19 infection. It turns out if you actually had a mild symptom, your antibody production is less than if you had more severe symptoms. But the key is the sweet spot, right? You don't want to get that sick and be in the ICU, but it may be where you were sick for like having a bad flu for 2 days, being in bed and not being able to get up. And um, so but that's a fine line, I can tell you. And so I don't wish that for anybody at all. So the only thing I would tell you that there is data, in fact, one of the Mount Sinai investigators published it, is that they have data up to 8 months that there are a portion of the population who had COVID-19 infections still have detectable and great immune response even at 8 months. And that is not the cutoff. That they cut it off at 8 months only because that's how far they've been able to study. So they'll continue to study those people, and we might end up that some people just will have um, an immune response 2 years down the line, 3 years down the line, because they had such a robust immune response. But it's hard to tell because even our antibody test is really not great as predicting if you're going to get reinfected again. All I can tell you is that, okay, you have antibodies. Does it really mean that you're completely protected? No. So that's why the answer is, even if you've been infected, you may want to consider waiting through 90 days from your infection to get vaccinated if your number comes up, but only because out for altruistic reasons, right? Meaning you want to give the vaccine to someone who hasn't been infected. But this ACIP or CDC, they don't say that you should not get the vaccine within 90 days of your infection. If you're if you're on that priority list, and even if you just got infected 2 weeks ago, because we now have very different way of responding to a natural infection, you it's your prerogative if you want to get the vaccine or not. So.
Some estimates are that as many as 100 million Americans have had COVID. We have a reporting of about 25 million. People think it's anywhere from 4 to 5 times that who've had asymptomatic or early disease or have not been tested. So this issue about the whole population is ultimately, the aim is to get everybody immunized. So lots and lots of people are going to be getting vaccines who have also had COVID. I did see some scientists comment that it appears that a vaccine post-COVID does have the same kind of booster effect. And I don't know, is there evidence to substantiate that there is a booster effect post-COVID with a vaccine, or is that just a hypothesis?
No, there's actually some evidence to say that if you had an infection and you were getting one of the Moderna or Pfizer vaccine, that if you just get one dose, you actually boost your immune response enough that the second dose may not be necessary because you're getting it as a booster. But again, that's not the recommendation. My official recommendation is that if you get the Pfizer or Moderna, you get your second dose for the Pfizer at 21 days, and you get your Moderna dose at 28 days, your second dose. The only time you would delay it if you actually got COVID infection in between that, and you just postpone it by 10 days, because we just don't want you to be contagious and coming to a vaccine pod. So
I have a quick question for Dr. Camins. I
Mhm.
don't think you addressed this in your opening comments, but relative to this, can you talk about, I know we saw a recent article from the CDC around the mixing of the different vaccines.
Yeah. So I can tell you that there's no reason why you can't mix, right? But at this point, because we are very dependent on the government giving us the vaccine pods will follow directions, meaning we will not mix Pfizer and Moderna. We will, because Pfizer and Moderna are pretty much the same. They have the same genetic code, right? So technically, but again, they've never been studied that way. That is not to say I got the Pfizer vaccine now. If I need a booster in about a year, I think I'm going to pick the Johnson and Johnson, right? That doesn't mean that I can't switch to a different brand once I've had the one vaccine. But if you started with one vaccine, you should definitely finish with that. And then, but for your booster, there's no reason why you can't switch.
Great. Well, that brings us to the end. We have a couple more minutes. Any final closing thoughts from Dr. Campbell or Dr. Camins? Or you-
That there aren't as many questions, so maybe we were pretty clear. Who knows? But I appreciate the invitation, and I really am.
Thank you
I'm
very much.
honored. Yeah.
Dr. Campbell, any last thoughts?
Likewise, I appreciate being able to be a part of this. And I think I would just continue to push, that we're not out of the woods yet, and still, the best defenses that we have. We'll take all of these things, but don't forget the simple things, the non-pharmaceutical interventions, and continue to drive that message to our employees and our loved ones.
Great. Well, thank you both very much. And thanks to everybody who joined the webinar. This is incredibly interesting as usual. And everybody stay healthy. Thank you very
Thank
much.
you.
Thank you.
Bye-bye.
Bye-bye.